Welcome, everyone, to our 57th virtual shadowing session, PA Spotlight Orthopedic Surgery with Andre, PAC. As always, this session will be recorded and posted on our YouTube channel, Pre-Health Virtual Shadowing, right after the session. If you have any questions regarding our program, please contact us on our Instagram at virtual shadowing or email us at virtualshadowing@gmail.com. This program is brought to you by our wonderful working group comprised of Reagan, Cheyenne, Taylor, Ali, myself, Rachel, Miriam, Elena, Ani, Rohit, Kiana, Aditya, and our 4 physicians, Dr. Fowler, Dr. Marchetti, Dr. Salazar, and Dr. Reno. To see more from our program, tune in for upcoming sessions. Next week, we have a nursing spotlight in med-surg. The following week, we have PA spotlight, acute care and surgery. And after that, we have specialty spotlight, cardiology. If you want to see the full calendar for next month, stay tuned to our Instagram. We'll be posting that next week. And then if you have any questions for our provider tonight, please put it in the chat as we go along. We'll be having 2 Q&As, one in the middle and one at the very end. And after the last Q&A, we will show the assessment, so how you can get credit for this session. Tonight, we have a wonderful speaker who is passionate about educating the future healthcare professionals and really advocating for PAs in every field. Dr. Salazar, would you like to add any words for our speaker, about our speaker?
Absolutely. Thank you so much, Rachel, and welcome, Andre. I am so happy to be here tonight. It's been a few weeks since I saw you. Life took some crazy turns, and a couple of unfortunate things that we got through came to our door, but we are very resilient human beings, and I'm so grateful for everybody's support. I am so delighted to welcome Andre tonight. Andre, I just want to thank you on behalf of the entire team and virtual shadowing all around. One of the biggest things that I'm very passionate about is teamwork and the multidisciplinary component that is medicine. And that's the only way we can provide phenomenal care to patients, and that's what we should be after. So physician assistants to me are completely valuable members of the team, and without them our shop doesn't run. So very grateful for you tonight. Really looking forward to what you want to share with us tonight.
Awesome. Thank you.
All right, I'll stop sharing screen and then you can start sharing.
All right, so let me do my screen here. This one. All right, is everyone able to see the presentation?
Yes, it looks good.
Awesome. Thank you for that amazing introduction, and thank you guys for joining in today. Hopefully you guys learn a lot. Definitely ask a lot of questions. I'm really passionate about orthopedic surgery. I've been doing it for almost 2 years, and there's never a dull moment. One day, like for example, yesterday we went in for clinic and we had to go do an emergent case. Didn't get home until 10 o'clock at night. And, it's one of those things where it keeps you on your toes. And I'm really happy with the job that I do and all the lives that I get to touch in the process. So let's dive in, and hopefully you guys will definitely get passionate about this field as well too. All right. All right, so just a few pointers about the surgical field, especially if you're thinking about going into surgery as a med student or as a PA student in the future. The hours are pretty long and brutal. It's definitely something you have to wrap your mind around. And sometimes things doesn't go out, doesn't go to plan. And it's one of those things where you have to adopt and you have to be able to do the best in any situation and think outside the box. For me as a PA, I work very closely with my attendant, and he's been an attendant for 10 years and I'm a PA for 2 years. And there's been times where things are just not going the way it was expected, and I have an idea and he's like, you know what, let's try that, and it works. So it's one of those things where surgery, it's always good to just be able to just say, hey, I have an idea, can this work? And you work as a team. I think that's very important. It's one of those things too, when things go bad, it can really go bad. And that's why it kind of trains you to expect the worst but hope for the best. And you always go in with the mindset that if always order something and have it available, because when you don't have it available, that's when you're gonna need it. For all the patients that are doing a shoulder replacement, I always have type and screen on board, um, because I just don't want to be in a situation where something happens, you hit an artery, there's bleeding out on the table. No, you're struggling to figure out if they have any kind of antibodies in their blood, giving them emergency releases, and it just makes things more complicated. So if you plan ahead, and that goes with everything in life, just make sure you plan for everything, and then just go with the flow. And another key thing that I tell all my students is make sure you use a bathroom before you go into surgery. These cases are very long. Like yesterday, the case was booked for a manipulation versus an open um, orthoplasty, and we tried to reduce the arm, and it didn't happen, so we had to go in. So it went from either a 10-minute case to now a 5-hour case. So you have to be prepared, and that's the goal with surgery: is always be prepared, and that will help you in life too as well. Um, so about my role as a PA in surgery, I first assist in all the cases. I go ahead, I mark the surgical site, I check the room, I talk to the reps, make sure everything is ready for the surgeon before he walks in the room. And a lot of times, the nurses, the staff, the anesthesiologists, they're asking you what the next steps are going to be. They're the one asking you to provide them with information to say, hey, this is what we're going to do. This is what we're going to need. Do we need this medication? Do we need TXA? Do we need blood products? And you have to be aware at 6 o'clock in the morning of what you need for that case. Not walking in like, I'm not sure. That doesn't look good for you as as a PA. Um, Being attentive is very key. Ask relevant questions, especially as a student. Um, in the clinic, I evaluate patients, I review labs, x rays, MRIs. Since I'm basically the right hand person, I know all the surgical cases step by step. I'm able to tell the patients exactly what we're going to do, how we're going to do it, and the protocols to follow after surgery. Procedures that I do in clinic, aspiration, injection, suturing, and all those things too. So it's a very diverse role when it comes to surgery, first assist.
Andre, you mentioned a first assist in anybody who ever enters the medical field and enters into an operating room. A surgeon rarely works by herself or himself, and a first assist is completely valuable. And it tends to be a very manual role, as you have here, holding instruments and pulling traction on an extremity. Was that something that attracted you about the field of orthopedics and
Yes, definitely.
specifically assist? Yeah.
Yes, definitely. Because I'm a very hands-on person. Like I work on my own car. On my spare time, that's one of the things I like to do is like fix something on the truck or change parts. So that's one of the things going into PE school. I kind of wanted to get my hands dirty. And one of the beautiful things I appreciate is my suturing. When I see a patient 2 weeks post-op and they're like, "Hey, I show everyone my incision," that's kind of like a business card. If you do a bad job, everyone's gonna know about it. So I definitely take pride in making sure the closure is amazing and it looks as close to plastic surgery as possible.
And with this type of job, you get the satisfaction of doing a lot of hands-on work. And then you mentioned kind of the trade-off is that you probably don't have as predictable a lifestyle going home at 10 p.m. sometimes. So there's a bit of a trade-off.
That is definitely one of the downsides, and I'll definitely talk on the pros and the cons. Obviously, the con is the time. It's definitely hard when it comes to family time. Um, but one of those things, you have to hopefully have a family that understands that sometimes things don't go to plan, and I mean, you're doing it for the good of others. Yesterday, this case could not wait. The patient was in a lot of pain, and it's something that could have caused further damage to the nerve, to vessels, staying dislocated. Um, so even though you're tired and you want to go home, you know that you're doing it for the greater good. All right. So just to go over a few things, I won't get into details about X-rays, but it's one of those things that's very important in medicine, um, to understand what you're looking for. And a lot of times people just read what's written by the radiologists, and sometimes it's really good to understand what you're seeing for yourself, because we're all humans. Things get missed, and especially in orthopedics, patients are going to ask you, like, what is this? Does this bone, is there supposed to be a space there? I get asked that question so many times, like, why is there a space between my ribs? Why is there space up in this section? Why? So you have to be able to kind of say, hey, this is normal anatomy. This is your clavicle. This is the humerus. This is the head of the humeral head, and this is where we're going to work on, and this is what you have, and this is why the surgery is important. So definitely knowing anatomy is going to be key for any specialty that you go into. So this is an example of uh, arthritis in the shoulder when there's bone on bone, and this is something kind of like our bread and butter, that we do shoulder replacements on. The a tendon that I work for is an upper extremity fellowship trained doctor. So our bread and butter is going to be like shoulder surgery. On call, we take care of hips, knee, ankles, but most of our time for elective surgery is going to be arthritis. So in this picture, you see the cartilage has basically deteriorated, um, and because of that, the bone has basically got closer together, and as you can tell, this is a lot of pain for patients. Any kind of movement, taking stuff off the shelf, reaching for stuff, just putting on their seatbelt while they're driving, brushing their teeth. Those are the things like people don't realize, that you're using your shoulders constantly. Just for expression, going like this, waving at someone, picking up your grandkids or the pet, whatever you do, this can cause like significant pain. So we definitely have a lot of patients who, after they've tried a lot of conservative treatments, including injection, physical therapy, surgery is usually that last step. And you have to be able to recognize that, be compassionate to the patient, and say, hey, we're here for you. This is what we do. I understand it's a scary process, but we're going to walk you through it. And you have to really listen to the patient, and then just be compassionate and allow them to trust you, because a lot of times as a PA, they might not even know what a PA is. They might not even know what you're doing, but they're trusting you in that moment to tell them, "Hey, I'm going to put you to sleep, cut you open, and you're going to be better." So
Hey,
it's
Andre,
it's it's scary.
we have a question. Can you
Sure.
explain what exactly is arthritis and why do you need surgery for it?
So that's a very good question. So the cartilage in the bone, has a space in between. If you can think about, like, if you can see my hand here, and over time that space kind of decrease as it deteriorates, and then the bone gets closer together. So there's a lot of friction, a lot of friction. Um, and if you're doing a lot of movements, that will cause significant pain, and it'll be very uncomfortable. Patients will have their an inability to sleep well at night, just limitations. They might not even able to reach over a certain degree, and there's only the only fix in this situation is actually to replace it
Oh, wow.
with surgery.
Andre, and things like arthritis, chronic inflammation of those joints is severely debilitating, and all of us have family members who've suffered with arthritis. Now, one of the main tenets kind of in medicine, and especially in surgery, and correct me if I'm wrong, is that to the best of our abilities, we try everything before surgery, and a lot of folks think that surgery is the best thing on earth, but there are some inherent risks. So is that accurate to say that everything should be tried before you kind of pursue
I agree.
surgery for something like this?
Definitely, I agree 100%. And for our practice, like we talked about non-surgical management, um, like you said, surgery has a big risk, and a lot of times we tell patients, let's try this first. Let's try an injection. Let's try physical therapy. Let's see if we can manage your pain or straighten your muscles before jumping the gun to surgery, because it does have a big risk.
Yeah, absolutely. I'm glad you do explain all of these things prior and try everything before surgery, because that does seem scary, cutting someone open.
Yeah, it is. I mean, you have, obviously the risk of nerve damage, the risk of blood loss, the risk of stroke, the risk of death. I mean, those are major things that you have to consider before you say, hey, sign me up, let's do this.
Yeah.
All right. So to touch on a few points, two of the main things that we do here in our practice for shoulder arthroplasty is what's called the anatomic, which is on the left side of the screen, and then the reverse prosthesis. And those are the two main um, prosthesis that I have currently in the market. And the reason for using one versus the other, it all depends on the rotator cuff muscles. And those are the muscles um, that does the movement of the shoulder. There's four rotator cuff muscles, four. And up top in this area, you have the supraspinatus. In the front, you have the subscapularis. In the back, you have the infraspinatus and teres minor, and those are the muscles that basically does all the movements or helps to do all the movements um, of the shoulder. And if those muscles, like you can imagine, in the older population is not intact, then that's when we rely on the reverse prosthesis, which is this prosthesis, and that uses the deltoid muscle for the movement. And again, this is something that you don't have to worry too much about until you get into the field, but at least when you see it again, you're like, oh, I know exactly what they're talking about.
Fingers crossed I can still remember all this.
You're like, yes, I remember that. That looks like the reverse. And the reason it's called the reverse, let me touch on that quickly, is that if you notice the ball is on this side, and that's more anatomic, and it looks like our natural anatomy. And if you look on the opposite, the ball is now on the reverse, and that's why it's called a reverse prosthesis.
Is there a reason why you use one or the other?
Yeah, so the reverse will be more for if the rotator cuff muscles are not intact. So if there's like a tear or if there's a damage, then we'll do the reverse because you're relying on that deltoid muscle to do the heavy lifting for you.
Gotcha.
It would be pretty safe to say, Andre, that one of the beautiful things in medicine is that everything is interrelated. So, for example, sometimes we think of shoulder arthritis as strictly just an actual joint issue, but it can be accompanied by things like rotator cuff muscle injuries, tendonitis, etc. And if you're overcompensating for a rotator cuff muscle tendon injury, you might be overusing your shoulder as well. So to me, it's always been very interesting how the body just doesn't function in a silo. Everything is interconnected.
Yeah. And another point too, I had a couple of misconceptions with orthopedic surgery. When I first applied for the job, I was like, I'm gonna treat old people all the time. You know, where's the fun in that? But then honestly, it's you made a good point with the overuse, and we've done shoulder replacements on younger patients, 30s, 40s, even 50s, because they've had significant arthritis, either because they were in the military, they have, you know, conditions. We've had to do a surgery on a patient who had severe avascular necrosis from steroid use. These are the things where the entire head of the humerus collapsed, and we had to do surgery on him. So it's not always old people when you think about orthopedic surgery.
Another question that we have, do you only use the reversed with, weak or damaged, or would you use a reverse for those with weak or deconditioned rotator cuff muscles too, or just damaged muscles?
So I would say the weakness has to do with it too. Sometimes, it's very important to try physical therapy first, and that's where the muscle building is going to be crucial in that process. A lot of times we book cases where it's anatomic versus reverse, and once we get in interop into surgery, we assess the muscle, look at the tissue quality. If it's weak, if it's damaged, then we'll say reverse will be the best option for him.
Gotcha. Well, those are my questions for now. I would love to hear more.
All right. So again, side by side, if you look, you'll see like the anatomic shoulder. This is a normal shoulder. We see the anatomic that looks just like the normal shoulder. And then on the other side, you'll see the reverse. And that's a good comparison. So you have an idea of the different terminology there. And here we go to complications. We see this a lot. Someone was climbing the ladder, fell off, motorcycle accidents. And here we have what's called, a proximal. This is where the proximal end is, humeral fracture, and that's a broken humerus bone. Over this side, we have kind of like greater tuberosity fracture. And a lot of times we can either use a plate or we have to replace it depending on how damaged this bone is. And this is a perfect example of, someone who fell, broke the humerus. We're able to use plate and screws, get it back lined up perfectly, and this is your post-op X-rays. So just another, quick anatomy of the elbow. We have the olecranon process here. The elbow is pretty intricate, but as long as you kind of go over things, you have an understanding of the anatomy. And here we go. This is a very common thing that we see is olecranon fractures. Again, it could just be from a bicycle accident or people walking from the grocery store, slip and just hit it in the right spot. And what we do for this, and this is a quick anatomy. We have the biceps that attach here. We have the triceps that attaches to the olecranon. And then obviously we have like the humerus bone and the ulna. So to fix that olecranon fracture, we again use plate and screws. And sometimes if it's really bad, we might have to do, if there's a fracture in the radial head, because this is where the radial head is. If there's a big fracture, we might have to do like a radial head arthroplasty, where we basically have to replace that. But for the olecranon, right now the technology has been built to use the plate and screws, and we want good fixation because the triceps attaches here. And as you know, that tricep muscle, it's needed to do the extension. We use that muscle a lot, biceps to triceps. So we definitely have to get that fixation well.
We have an interesting question. Do you see a lot of injuries with baseball players and in their elbows?
Yeah. So I live in the Orlando area, Dr. Phillips, and we're very fortunate to have a lot of like professional athletes that come through our practice, NFL, baseball, basketball. It's a very diverse area, so we get to work. I mean, obviously can't go into details against HIPAA, but we definitely get to work with a lot of baseball players, and we see mostly like tennis elbow or inflammation in the joint from overthrowing. where they kind of like sprain a muscle,
Mhm.
but a few times you'll definitely get that broken bone.
Nita highlights, Andre, to something that we said before. One of the biggest misconceptions about surgery is that surgery. You're going to discuss kind of lifestyle here shortly, but just like these athletes, the overwhelming majority of time you spend with patients, including athletes, is going to be non-operative time
Hmm.
and treatment plans, etc.
Yeah, definitely, because you have to also consider, the lifestyle that they want. Some people are, hey, I need to get back into this. What's the best option I can do at this moment? I want to put off surgery for another 10 years. I want to put off, um, I have a life event that's coming up next month. And you have to, one, know what's best for them in that moment and also be understanding, because
Mhm.
at the end of the day, you have some providers that are like, okay, you walk in my office, I'm gonna cut you. We're gonna do surgery, 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 surgery. But that's not what's best for the patient. We've definitely seen uh, great outcomes from non-surgical. Just let the bone heal. It's in a good position, and they didn't have to have any plates or screws.
Wow. So it seems like you have sometimes really tough decisions or tough talks with your patients about if
Yeah.
surgery is really necessary, or like, some patients don't want surgery or because of their lifestyle. How did you develop those bedside manners, and how did you develop, talking about these tough topics with your patients, like easing them into it?
I think the best thing you can do is always put yourself in their shoes, and that's the first thing I said to the patient is like, whenever, I think a lot of patients are resistant to surgery. No one really wants surgery.
Mhm.
So you have to come across in a way that's, if I was in your position, this is what I would do. If this was my mom's x-ray, this is what I would tell her to do. If this was my dad, if this was my brother, if this was my sister, I'm going to tell you the same information that I would tell them. Because when they walk in your room, that person is not a paycheck. They're not, a list on your schedule. They're family. And that's what you have to treat them as. And you give them all the options that are available to them. And you kind of guide them in that direction to say, hey, you know what? If I was in your position, this is what I would do.
Mhm.
I've actually spoken to, um, we've had patients who are like 95, 99, 100, that come into the office. At that point, at 95, surgery is out of the question. The risk of surgery is far more greater than the risk, the benefit of the pain that you're going to take away. And a lot of times, some of those patients are like, you know what? I wish I had this knee replaced 30 years ago. I wish
Mhm.
I had the shoulder replaced 20 years ago. So I've able to learn from my patients, learn from my experiences with life in general. And even yesterday, I had a patient that came in. I gave her a cortisone injection into her knee. But I had a tough conversation with her, and I was like, listen, this is your fourth injection. Your arthritis is very bad. You're
Mhm.
70, but you have good health. I would consider doing the surgery now before you get to 90. And all you can think about is just injection after injection after injection. And, it took an extra 5 or 10 minutes out of my, timeline that I wanted to spend in the room. But I think it really resonated with her. And she's considering, signing up for surgery, not with us, because we don't do that surgery, because we're upper extremity, but she's going to
Mhm.
talk with a knee specialist to get the procedure done because she was scared.
Yeah.
Andre, you may be the patient, as we're seeing in the chat, fully agree with the answer you give the patient in regards to their therapy may not be what they want to hear. You either need surgery, I don't like that idea, or no, you probably don't need surgery, but they want the surgery. How do you leverage your time and resources when you might be a second opinion to folks, or people are going to tell you, well, I'm going to go seek a second opinion, see what they say, hoping they'll get a different answer? How do you use
Yeah.
your time with those patients?
I think, you have to realize that as long as you do what's best, you can sleep well at night. Um, like, I don't think I would feel good with myself if I push surgery on someone who didn't need it and something bad happens. Even if it was a great outcome, I still would not feel good about myself knowing that the reason I pushed this is because we wanted extra, surgery time or more money in the practice. And a lot of times you have to have those hard discussion with patients and say, hey, your surgery is not the best option for you. Perfect example. I had a patient who has history of DVTs, stents, big cardiac history, came in with a clavicle fracture that, was mildly displaced. No, he wanted surgery. And the reason he wants surgery is because he wants to get back to go to the beach, get back to go traveling instead of just staying home and rest. And, we do surgery. You'd think we want to push surgery, but his cardiac risk is higher. And that's something I had to explain to the patients like, hey, your age, your cardiac history, this is going to heal up really nicely for you. Just give it some time.
Wow. I guess you didn't realize, you also need to heal from surgery too.
Exactly.
I mean, I know the beach is great, especially when it's really hot outside, but like, let's heal first.
Yeah, no, it's important. You have to do, as long as you know you did your best, you gave the best opinion, and you did what you can do. I think that's all you can do in medicine.
Just be the best support and best source of information that you can be. That's
Yeah.
beautiful. All right, I'm ready for the next slide. Y'all, it's gory, and I hope
Yep,
you like
here we
it.
go. So this is, a perfect example. We're holding actually the radial nerve. We actually had a fracture here on the humerus. We had another fracture here, so we basically had to do an osteotomy, meaning we cut off the olecranon on purpose to get exposure, so we could put a plate and screw. Obviously, we want to protect the nerve in surgery. That's like the golden thing you want to look for. It's like we have to protect the nerve. If you see something that looks slightly like the nerve, you're like, stop. Let's move very delicately around this. Because one of the big things, with getting damage to the radial nerve is what's called like a wrist drop. And that's obviously very debilitating. It's not something someone wants to have after surgery. It's kind of like uh, a downer for the surgeon as well and the team, because you feel like you probably failed the patient in some way, even though you fix their fracture, you caused something else in the process. So it's a lot of risks, going into surgery, and that's what patients need to understand. Like, um, things can go bad, you know, and this is a perfect example where that blends in unless you're really looking for it.
That's one of the most impressive aspects about the surgical field and procedural medicine is, in cadavers or in the books, the anatomy, the radial nerve is kind of nice and tidy and clean and white. Really, in reality, is going to be
Yeah,
deep in there with a bunch of mush where you're also going to have a bunch of blood vessels, bone fragments, etc. So,
yeah.
Andre, when you are making your incision and exposing the area, do you make it a priority first then to identify these structures and mark them with a string and make sure they're out of the way?
Yes, exactly. Number one priority. Definitely getting down to the area where they're supposed to be. You look for it. Obviously, some patients are different in terms of their body habitus, meaning thin versus, not so thin. Um, and things change, especially if there's a revision surgery, a fracture. If you look closely, this bone is really close to the nerve. And this is what's so important about understanding fractures and how some of these fractures can innately just basically cause the damage and why it's important to fix it.
Mhm.
I want to
Oh,
point out in that picture too that yellow tint is on the patient's skin. That's a film that is used in surgery that goes above the patient's skin to try to keep the area clean. And you can see little bits and pieces of the patient's actual skin
Yes,
underneath.
right here.
When I first
Perfect.
did surgery, I was like, why is the patient's skin like that? That looks
Yeah,
so.
yeah, it's the Aya band. That's a very good point. It definitely helps, keep because the skin has bacteria, and you want to make sure that when you make a cut, we do a great job irrigating, washing it out, doing antibiotics in the wound. But if you can keep that bacteria off that surgical field, that will save you so much headache with post-op infections.
yeah. We have a question. How do you differentiate between like the radial nerve and other nerves from blood vessels?
That's a very good question. It has, and don't have the blood vessel here, but it definitely has a difference in color. It has a difference in texture. Obviously, with something like the artery, it's going to be, pulsating. So it's a feel. Knowing the anatomy of the location, we're looking at the posterior aspect of the shoulder. We know that the radial nerve runs behind the posterior aspect of the shoulder. So we're able to kind of like, okay, this is where it's supposed to be. Let's go here. Let's look for it. And then we kind of identify things around the structure.
Gotcha. And so that string is just to identify the nerve,
Yeah,
right?
that's called like a nerve loop, and that's just to basically hold the nerve because the nerve is very sensitive as well.
Mm-hmm.
And manipulating the elbow, we're trying to avoid the nerve getting stretched and damaged. So it's always good to kind of pull it to the side and do your manipulation with the screws. Because the worst thing someone can ever do, well, not the worst, but a really bad thing is to put a plate on a bone and then realizing that the nerve is under the plate.
Oh,
It's
that sounds
it's
painful.
it's probably happened before.
Oh no.
You're using some pretty heavy duty tools to do this. These are not like tiny little drills. These are actually adult size the
Yeah,
drills and hammers and screwdrivers. And so, yeah, absolutely catastrophic. If you ever want to wind up in court, you can see how very easily you can misidentify or miss a radial nerve, and then just go ahead and put a plate on top of that and drill it in there. So
yeah.
Oof. What is the next step if like a nerve gets under the plate or say a nerve gets stretched? Like what is the next step?
Yeah, if a nerve gets damaged, you definitely want to get vascular, on board, and that's why it's so important to have like a team, especially in the hospital. Like big cases like this, we're gonna be working in the hospital. For smaller cases, where it's like a orthoscopic surgery, where the risk of nerve damage or something is very minimal, we can do that at like an outpatient surgical center. But at a hospital, you have everyone on board. You get everyone involved, vascular,
Mhm.
general surgery. Um, if you thoracic, if something happens, and cardiology, you have everyone at your fingertips, which is amazing in the hospital. And that's why it's so important for it to have that team dynamic.
So do you work closely with other fields? Like,
We do. A lot of patients, and this is another thing too that you'll eventually learn that I didn't know going into orthopedics is that you're going to work very closely with neurology.
oh.
You're going to work very closely with rheumatology.
Mhm.
A patient today, 34 years old, bilateral hand pain, multiple areas that have, in a very young age, my differential is going to include rheumatology disorder. I'm going to order rheumatoid factors. I'm going to order anti CCP, just the different markers. And then if I get that positive result, I'm going to refer to a rheumatologist. A patient comes in with shoulder pain, and they're telling me, hey, I've been getting this numbness, tingling in my fingers bilaterally. Okay, do you have neck pain? Yeah, I do feel like my neck hurts sometimes. Let's get x-ray. We look at the x-rays, and there's arthritic changes, there's a disc that's bulging, there's a disc that's slipping, there's something going on, we got to get her to neurosurgery.
Gotcha.
So there's always something that's like interrelated with orthopedics. It's never
Mhm.
just broken stuff.
Yeah, there's more to it.
There's
Wow, that's
definitely
really
more.
incredible. I thought, you mainly would work with radiology, but it's cool that you like work with so many different fields. Well, if you could, like for a couple seconds or minutes, however, could you more in detail describe like what we're seeing? Like some students and myself, I don't know what I'm looking at. You pointed out the nerve, you pointed out the ulcron. What are the blobby things on the
So
bone? Is it
that's so
tissue?
right in here we have like what's called like the fat layer, and the skin,
Hmm.
and this is the tricep muscle. And the
Hmm.
triceps attaches right to the olecranon, which we had to actually make a cut to peel. So right now, what you're looking at is basically where I'm pointing on myself, the back of the elbow, and the tricep muscle, which is here, is the structure in this aspect.
Oh.
Yeah, so right in here is where we're working. So the patient is laying supine, and then we're
Mhm.
twisting the arm, going back and forth, extending and twisting back and forth. So that's why it's important to move this nerve, the radial nerve, over to the side during this manipulation, that it's not getting compressed or damaged.
Gotcha. Cool. Thanks for clarifying on that.
No
There's
problem.
so many things going on. It looks cool. It looks really cool.
Awesome. So this is another surgery that we do as well, like a distal biceps repair. And if you look at the quick anatomy, the biceps, as the word suggests, has two heads. The long head, the short head, and then it attaches right here at the insertion point. And this is a lot of times we see this in bodybuilders, and again, this is another surgery we mostly do on people in their 30s, who are working out at the gym, bench pressing like 300 pounds, very bulky, and they hear a snap.
Oh,
You know, we go in, we reattach it with, we drill into the bone, put a suture anchor, tie that suture into the tendon, and tack it back down to the bone.
wait. So you repair like torn muscles by drilling it to the bone?
Yes,
Oh
because
my
the
goodness.
muscles are attached to the bone through
Mhm.
tendons,
Yeah.
and unfortunately, tendons doesn't heal like bone does. It heals with scar, and it's not as strong as it used to be. So the tendon is very, very strong. So what you'll have to do is basically tack it back down to the bone, and then allow it just to heal to the footprint of the bone.
Oh, gotcha.
Yeah. And as you can see here in this diagram, the long head of the biceps goes over the humerus, and that kind of keeps that humerus in place as kind of like a placeholder, and that attaches to the superior aspect, which is called a glenoid, and then the short head goes to the coracoid process. And that is something too that you have to point out to patients when you're looking at x-rays, or they're asking about, oh, it hurts here, it hurts there, and it kind of helps you narrow down your differential.
Andre, I want to point out for this last slide, for example, is that for some procedures like a biceps repair distally, kind of closer to the elbow, notice how small the incision is, and even more important to know well the anatomy so that you leave patients with less of a scar. Would you say that that's a consideration for non-fracture type of injuries, such as a
Absolutely.
tendon?
Absolutely, because one of the things too, it depends on your area that you work in. In my area, like I said, we cater to a very diverse group, and majority of the patients are well off, and they require a lot. So, having that minimal scar, that beautiful, nice line that looks like a hair, um, that's what they're going to show their friends. That's what they're going to tell everyone. Hey, I had a surgery. Can you tell? If you can't tell because they've healed so well, they're going to tell their friend. Their friend's going to tell their friend, and then and that's how you generate business.
Mhm.
And you have to think about that too, where as a PA, the surgeon, they're there to see the surgeon and they're happy, but they want to know what your role is as a PA. And if you're the person who gives them that nice, pretty incision, they're going to respect you for that. They're going to, you know, when they come for their post op visits, hear what you have to say and say, you know what, this guy knows what he's talking about. I'm going to trust his opinion, and move on. Because one of the biggest challenges that I have, as a PA, and I definitely have no filter on saying this to you guys. Um, a lot of times people don't want to see a PA,
Mm.
so you have to give them the confidence to say, you know what, I know what the surgeon is thinking. I know that exactly what's going to happen. We're working as a team. you know Whatever I say, he can come in the room and back me up 100%, because I know it will just be like coming from his mouth.
Mhm.
And we work together, and we're going to do what's best for you. And I think if they realize that, they're like, okay, well, I trust you. I hear what you have to say. I don't need to see the surgeon.
Andre, I want to share a little bit of I'm going to drop a knowledge bomb to all of our friends tonight, and I want to make it absolutely clear to folks. If you're a physician, if that's your future, and you're working with PAs, nurse practitioners, nurses, and they're part of your team, I want you to stick up for your team and to let the patient know ahead of time, set good expectations. Listen, my name is Dr. Salazar. You're going to be working with me. You're going to be working with my PA, Mr. Daly. And he and I work on the same team. He's got decision-making power. And if you have any questions, you can ask him. So I want to make sure that our learners out there stick up for their team members, because without our team, nothing happens. And trust me when I tell you, many physicians over the years have let that arrogance kind of take over their practice and not stick up for their team, and that is a recipe for disaster. So I just want to make that clear. You're always part of the team, and we always got you back.
Yeah, thank you. And that's a very good point, because I've been in a situation before, where a fellow healthcare patient, she's a nurse, and she's like, hey, she's very concerned about her son. So when I was explaining to her, okay, what we're gonna do, and that I'm gonna do the closing, she was concerned. She's like, wait, you're doing the closing? Why is the surgeon not closing my son's incision? And then, my attendant came in and was like, hey, he's really good at what he does, and he's going to be the one who's going to close. And, I have to gain her trust, because, again, this was the first time we've met. She was very pleased. She had a great outcome. And now, moving forward, we have a great relationship when we see each other. But, like Dr. Salazar said, my attendant stood up in that moment and said, you know what? No, Andre's going to do the closure. This is a part of his role in my team. And, I'm not going to make an exception for you because you have something against PAs.
Oh, I'm so happy that you have such a great attending and such a great relationship with him. Oh, I'm glad.
Yes.
That's just so wholesome.
Yes. I'm very, very, very lucky and very happy.
That's amazing. All
All
right.
right. So a few of the things I wanted to point out, we do see a lot of hips. A lot of times, we have patients, especially in the older population at nursing home, they're getting out of their chairs, uh, going to the grocery store, and make a wrong move, and they basically fall over. So, in knowing the classification of where the fracture happens, there's different classifications, different names for where the fracture is, and that's important once you start going into the anatomy of things, especially reading X-rays, explaining to the patient, "Hey, this fracture is really bad. We have to fix it." Versus, "This fracture is not so bad. Let's give it some time." And knowing the research, knowing what the study says about the longevity of certain fractures is super important. So it definitely comes into the decision making process. This is an example of a patient that we saw recently. hip fracture, going back to the classification, this will be considered like a subtrochanteric fracture. Um, Looking at this one, this is an intertrochanteric fracture because it's higher up. This is very, very common. We see it a lot, especially during call. Um, and one advice I will definitely give everyone that's listening today, I've seen a lot of people put their feet on the dashboard in the passenger seat while they're driving. Please stop. um, when I've seen accidents, and it's dislocation. It goes where it's not supposed to go. Um, and it's a very, very bad habit. I've seen a lot of patients, people do.
Andre, thank you for pointing that out. Hip injuries can be absolutely catastrophic, especially in older folks. Can you please, since we have this x-ray up and maybe the one before, can you please explain to our learners the difference between the hip and the pelvis? Sometimes I hear learners kind of using one versus the other, but there are differences. Can you explain the difference?
Sure. So if we look here, we can see like in kind of like the pelvic area. Over this section, we're going to consider this like the hip, the femoral bone, and that's one of the, we have the artery that goes, that's a very big artery. And sometimes in the like gunshot wound victims, or if there's a major fracture, you have to consider, is there damage to any of those vessels? And that's very important. So, looking at the x-rays, we can definitely see, differentiate between like the pelvis, the hip, and then as you get lower, you'll see the knee and going at that sort.
Patients can die from pelvis fractures, and that's another type of injury that you can get from dashboards, and being pinned is for your actual pelvis, that big cup to become separated, and you can have vessel injuries from hemorrhage within those vessel injuries. Hips can be equally as catastrophic, though.
Yeah.
If you're ever rounding with me in the hospital, and if I ask you the difference between hip and pelvis, now you know.
There we go. And one other thing too is that, a lot of times those injuries get missed easily on x-rays. Because, you focus on the main picture, you're thinking, oh, we can obviously see that there's a fracture, but there might be something laying in the background in the pelvis area that you're not looking at. And that's super important.
Hey, Andre, can you point on this X-ray, like the different types of fractures that you mentioned in the previous slide?
Sure.
Like,
Yeah,
I
so
just
here
want
we
to
have,
get on it.
right at the neck, have
Mhm,
like the transcervical. Right below that, you have what's called like the intertrochanteric, and then below that you have, sub, meaning below, kind of
mhm,
that trochanteric area. A lot of times, just to people might be familiar with what's called like a trochanteric bursitis, and there's a little sac that sits right around this area that gets inflamed. Um, so just going based on that location, you can say, okay, this is intertrochanteric. At the neck, we can have that subcapital, and then below that, we have that trochanteric fracture as well.
gotcha. Well, I hope we can take a quick pause because we actually have quite a few questions piling up. So do you mind
Sure.
if we have the middle Q&A right now? Okay, so a question that we have is, do you often have to deal with bone cancer or is it mainly injuries?
Yes, we've had a few. Unfortunately, that's not our specialty. We do refer patients out if we see something on X-ray. A lot of times we're like, yeah, something looks funny. We get either an MRI, CT scan, and especially with the surgical history, we'll most likely refer them over to someone who's like an oncology orthopedic surgery. The beauty about medicine is that there's so many different specialties.
Mhm.
You have someone who just focuses directly on tumor cases. You have someone who focuses on kids. You have someone who focuses on spine, and all of this is still under the orthopedic umbrella.
Yeah.
But it's important. Just you want to go to a specialist.
Yeah.
Oncology or orthopedics is totally different animal, and for all of these specialties you're mentioning, that's a fellowship. So you would have to do your residency after medical school in orthopedics, then do your fellowship in oncology, trauma, hand, spine, kids, as you mentioned. So it's a long road.
Yeah. And the good thing
Sounds
is that
exciting.
there's just so many different things and we work as a team. I think that's the most important thing. That is, if there's just one thing you should take away from this entire lecture, is how important it is to be, a team player. I
Mhm.
think if you can demonstrate that in your interview, whenever you go for school or for your job, if you can convince the person across from the table to say, "Hey, I'm going to be a part of this team because I'm passionate about what I'm going to do, and I'm going to help the patient in the best way I can."
Gotcha. All right. So you've mentioned several times your amazing closure skills and how like no one can see the scars after you close them up. What factors go into how big or visible a scar is after a surgery? And then do you what makes your like stitching or anything like so great that no one can see it?
So I think one of the main things for me is I take my time.
Mhm.
A lot of times, in the OR, people are rushing. They're like, "Hey, we need to get that second case in," and you have to be mindful. Also, you don't want to sit there and take forever to do this, but you don't want to rush it. And I think I've definitely learned from my attendant. I've shadowed plastics. I've shadowed so many people to learn from them because this is kind of like my touch.
Mhm.
This is I help in the surgery, help with the manipulation, but this is my moment where I'm in control of the room. My attendant is gone. He's doing his, notes and talking to family, but I'm the last one, on that table, and I want to make sure that I do a very good job. So it depends on, whether I use monocryl versus like a zip line versus like a vicryl. It all depends on the different material,
Mhm.
and it also depends on this incision too, like the size. When I first started, we started using staples, and some patients will do well with the staples, like the older population, and some patients will have like little track marks, and I didn't like it.
Mhm.
Some people don't care, but for me, like I look at that's the first thing I look at when I see the patient walk in the room.
Mhm.
It's like a phlebotomist. Like you ask any phlebotomist right now, what's the first thing they look at when they meet someone for the first time? And they're going to tell you, they look at their veins. They're like, "Oh, you have a good vein." That might be a weird conversation, but they're going to say that.
Yeah. Um, that's really funny. I think that's really funny that you just noticed that. So we have an interesting question. So, if someone had keloid skin, what is the best way for a physician or a PA to prevent, keloids from happening when you're closing up an incision?
Yeah, so I think that's very important. We do have, some patients with that condition. Doing a very tight closure is important. Doing like compression as well, whether it's through, the glue like a dermabond on the top layer, or an extra compression with the dressing. That's possible. There's also injection that you can do with cortisone. So there's definitely different options as well, and obviously sometimes you can't prevent everything. Not everything's gonna look amazing. You might have to get dermatology involved later once the scars heal for them to do treatments like laser or injections.
Gotcha. Um, can you like briefly describe like the differences between the types of sutures that you mentioned?
Yeah, in terms of like Vicryl
Yeah.
versus nylon. So the
Hmm.
Vicryl is going to be more something that's like absorbable. Nylon is going to be non-absorbable. So you have to look at the aspect versus absorbable versus non-absorbable. And there's just so many different material. It's just basically the material has this different use. Some might dissolve in 7 days, some might dissolve in 14 days. And then you also have to think about the size of the needle, the size of the suture itself. And then there's a whole different criteria if it's on the hand versus on the body. If you want to use the 3-0 versus like a 2-0, 4-0, it's pretty. Once you get a hang of it, you're like, oh yeah, we're gonna use the 4 or there.
You just look at it and you know, I
Yeah.
can do this.
Yeah, there's
Gotcha.
some little guidelines. Ultimately, the cosmetic outcome is probably the most important thing and the thing that folks care about the most. The second to kind of good pain relief and and fixing the structure that was being worked on. So you pick up little tricks and along the way. But even all the training that folks like Andre have to go through to find the best possible material, suture, and type to get the best cosmetic outcome.
Yeah. And the good thing is that you're learning from, amazing doctors who have, they've studied things in medical school. They're giving you the knowledge because everyone wants you to be successful. No one
Mhm.
wants you to fail. If you're a part of they say the chain is as strong as its weakest link. As a team player, people who have 20 years of experience are going to be working next to someone who just came out of school. And it's important for that person who just came out of school to absorb and learn and never be cocky, never say, I know it all. I have everything. I don't need help. Like, we always need help. You're always learning. And it's important to learn from everyone, people who do bad, people who do good, and just keep an open mind.
That's beautifully said. Another question that we have is, have you ever had a bone fracturing because of an implant itself? And what do you do to approach that?
That's a very, very good question. That's a star question right there. So yeah, a lot of times in surgery, the one of the risk is a fracture. So what we'll do to fix it depends on, if we're working on the shoulder, we'll do what's called a cerclage, and that's basically like tying a suture around that area and doing a really tight knot to keep it in place. Because eventually, by giving it time, it will heal very strong. So that's a very good question.
Gotcha. Now, some of our students tonight have had their own surgeries and unfortunately, had nerve damage. And so a couple of them are curious on how sensitive is the nerve during surgery? Does it take much pressure to create nerve damage, or is it just someone just making a mistake?
It's very sensitive, very, very sensitive. A lot of times, you can try your best to go through the waters and move certain nerves around. But in order to get to where you need to, unfortunately, sometimes things have to be stretched. It has to be moved out of place. And when a nerve is stretched, I've seen a nerve that starts here and goes to there, and it is just stretched. It has that ability to take that much force.
Mhm.
And it all depends on where in a part of your body the nerve is. But I say sometimes it takes some time to get back to normal or, close to normal as possible.
Gotcha. And then one more question before we move on to the second half, because I'm really excited for the second half too. This is a fun question. Do you have a favorite part of the body or favorite surgery you like to assist on or work on? And why?
I would say it's the clavicle. I really like the clavicle for some reason. It's a very, I think it's more the positioning.
Mm.
Because the patient is more like supine. A lot of the shoulders are like what's considered like a beach chair. If you see someone kind of lounging at the beach in that sit up position, so
Mhm.
you're not hunched over as much, in
Uh,
that position. And I think it's just the way it looks because it kind of blends in with that clavicle, that shoulder blade. So it's really those are the incisions that you're looking like, wait, is there a wrist surgery? The other ones on the shoulder you can definitely tell. But the clavicle, I think I really like the clavicle.
nice. Well, let's move on to the next half. I'm really excited. And then after the end, we'll, do more questions.
Awesome. All right. So we talked about the hip fractures, or they're very common. We see this a lot on call. I'm on call this weekend actually, and I'm pretty sure we're gonna get another hip fracture. We see it from people leaving Publix or Walmart, slip, hit the leg in just the right place. And, with as patients get older, the quality and the strength of their bone, decreases. And I'm pretty sure you guys were probably familiar with, osteoporosis, where there's just like the degrading of the, weakening of the bone essentially. Um, and the bones are not as strong like they used to when you're younger. So especially for the older population, they're more prone to fractures. Patients in the nursing home, sometimes they're not getting the proper care, or they're not getting the attention that they need. So they are definitely more prone to injuries, and that's something you have to watch out for as well. All right. So one of the cool things that we do for an intertrochanteric fracture is what's called like a hip nail, and this is kind of like the prosthesis that we use. And I'll show you. Have an example here. So there's a fracture right here on the shaft of the femur. We'll make a hole, like a very tiny incision. We use what's called like a sounder to, on one, we have to reduce the fracture, making it align. And that's what reduction is. Anytime you hear the word reduction, is basically so we can fix it. So we get the fracture reduced. We use this rod that we put that in place. We put the nail in, and then we put the screws. Sounds very simple, but it's definitely time consuming because you have to get the right angle. With the hip, it's very tricky because you don't want someone to give someone a limb length discrepancy, meaning that the fracture is too distracted. No, one leg is longer than the other. And that's a big deformity when you can see someone walk and they're walking with kind of a limp. So it's very important to you kind of line up things to where it wants to go. The beautiful thing about bones is that it's going to want to fit into place. It's very rare that that you're going to have a fracture that you can't tell which way it goes. It wants to kind of fit back into the place that it was fractured.
Cool,
Andre,
cool.
that's a
So
very, very um, a big hip fracture like that. I just want to point out to the learners, like what an invasive thing putting an intramedullary nail like this really is. That's where you got to have some muscles driving that thing in there.
yeah,
How would you describe the feeling of having to drive an instrument of this magnitude into a patient's femur?
yeah, it's definitely time consuming. You will get your workout, and that's the most important, especially if you're like into like bodybuilding. You're like, yeah, I'm gonna hammer stuff, and I mean, you will definitely get your workout. You're gonna be sore, especially after a long day. I mean, because you have like a regular hammer, it's like building something, and you're like, bam, 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 bam. You're hitting that thing in, and it looks pretty brutal. It looks brutal, especially for a knee surgery. Like I've seen surgeons go like boom,
Oh my goodness.
boom, and you're like, wait, are you really doing that to the patient's knee? But it's what you have to do to get this stuff in.
Uh,
Um, and
we had an interesting question. How can you drill so much or like, hit the bone so much without really affecting the inside of the bone? Like, does it affect the inside of the bone, like the bone marrow?
So it's the bone is very strong, and it's really an amazing part of our body where it's really strong. It can take, even though it looks small and it looks fragile. Most of these fractures are from really big forces. You'll see a small fracture, for example, in the clavicle, or a small fracture in the shoulder. And these are from like a T-boned accident, or from a rollover accident, or someone fell off a sixth flight of stairs, or a ladder. So it takes a very big force to cause the bone to break. So, knowing exactly where to go, it's like going into a tunnel, in this sense. And you can cause fractures too, obviously. But I
Mhm.
think knowing how much stress you can put on the bone, and being very attentive, and also being, going at a good pace helps you to predict if you're in the right place and not cause any problems.
Gotcha. And so it doesn't affect the bone marrow or anything like that?
Mm-mm.
Gotcha. Cool. Right. I'm ready to hear more.
All right, here we go. So, quick an anatomy about the ankle. This is something that you probably see a lot in the ED. We get calls from the ED all the time. Someone twists, a soccer player, someone, a dancer, or jumping on the trampoline. You name it, whatever you can think about, we can definitely see an ankle fracture. As you're going to see that a lot, especially if you work in the emergency department. So this is like a quick anatomy, or just about the bone, the metatarsal, the tibia, the fibula, and one of the big classifications about the location of the ankle fractures is like the Weber criteria, and it has like different stuff about if it's Weber A, it's here versus Weber B versus Weber C, and then obviously this is kind of like a normal anatomy, tibia, the fibula of the ankle. So a lot of times, people, like we said, get these injuries from like a twisting injury. Um, either it's playing soccer, basketball, playing tennis, all these sports, you're putting a lot of stress on your ligaments, you're putting a lot of stress on the bones, and this is where essentially that can lead to a fracture. We go in, we identify the fracture with those tiny incisions again. Sometimes we can just use like one screw to kind of prop up that bone back in place, and then on the other side, we can use plates and screws as well.
Andre,
So
can you discuss briefly, specifically for ankle injuries? It seems to me like this is one of the more common places where we get hardware loosening, where patients have had a surgery and in the past, or maybe even recent past, and then they come in with additional swelling or new pain after the surgery, and you get an X-ray and you find some of the hardware has been loosened. Is that just gonna kind of a random thing from my practice, or do you see hardware loosening more commonly in the ankle than other areas of the body?
I think we see it quite a lot in different places, but it's very common in the ankle. Like you said, it could be from the stress. It's a weight bearing joint. People are more active and they're gonna, twist and turn. It could be another issue with compliance as well. A lot of times we tell patients you can't do a lot of activities for 8 weeks, and they're like, I feel fine. I'm gonna go for a quick jog. I'm gonna go back to playing ball. So compliance plays a big issue. Also making that determination as the provider, what screw length you want to do, where you're gonna place it, getting good fixation. I mean, those are like critical things while you're making a decision, that could eventually lead to complications. Like if the screw is too short, you're not going to get good fixation. If the screw is too long, then it can stick out and cause hardware problems. So it's definitely making that decision of what best size, and knowing it's important to measure the screw length with like what we have like an internal ruler when you do the drilling to say, okay, I want a size 18 versus a size 20. And I
Excellent.
think that's very important as well.
And just a reminder that these are not screws you find at Lowe's or Home Depot. Can you speak a little bit about the materials? Somebody in the chat wanted to ask about the safety of having hardware like this, and for folks who want to go MRI.
Yeah, no, it's definitely, we have material that's made of like stainless steel, especially the plate. You have some material that's made of titanium. The good thing is that a lot of these materials are, you know, majority of the times MRI safe. These manufacturers, they know that eventually people have to get MRIs, and it's important to have material that's more versatile. Especially, we have the big question: oh, am I going to set off the alarm when I go flying? Is it gonna go beep 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 beep? And then for some knees might actually give some kind of warning when you go through the TSA, but they do scans, and we give people implant cards, and obviously they can see your incision to know that, okay, I had surgery. Um, but for the most part, these implants are very safe, and there's so many different implants on the market, and that's why it's important to again know which one you want to use, um, or which one is going to be best for your patient, and it's kind of interesting, knowing which company to go with from time to time.
One of our students asked, is there typically a certain size that you use for a certain age, or is it just really dependent on like case by case?
It's definitely a very good question. And, it's definitely based on case by case where, some, some people's bone are different. Everyone's bone's different actually. So you might have a younger patient who has, slightly bigger bones than someone who's older. You have to think about the consistency too. With are they have osteoporosis? Are they older? Are they younger? Um, will this the most important thing about fractures, and hopefully you guys will take this knowledge away, is that whenever there's a fracture, say for instance in this side, research has shown that's important to get at least 3 screws away from the fracture, because of the stress, the Newton forces that are going on it, that if there's less fixation, it's going to fail. So that's why if you see x-rays, you'll probably see most screws away from the fracture site is either 3 to 4, and that's just to keep that stabilization.
Oh, wow. I did not know that. That's pretty cool.
Um,
I would love to hear more.
all right, so one of the cool things again about orthopedic surgery, it's not always about fixing bones. One of our patients that we had to do, he was dry. Well, this is a story that we got, and he was driving home and heard a gunshot, and then realized that he's bleeding while he was driving home. So he came in. Though we did X-rays, we saw that there was like a fragment in his leg. Eventually, the body was kind of like pushing it out, and we could see where it was getting like erythematous. It was like really angry. So we've done, we occasionally do like foreign body removal. I mean, that's something that can also be done by general surgery. It's also something that can be done by plastics as well. But
God,
he was a patient of us, and he's like, "Hey, I trust you guys. Can you go in and take this out?" And we did. So that was actually pretty cool.
that's crazy. W- Besides, this bullet, what is like the craziest thing you've pulled out of a patient?
So an actual nail. This was on my last call. This guy was fixing something in his garage, and the nail gun literally went off and went through his thigh, and it was literally probably a centimeter off like the sciatic nerve. We had
Oh,
to get CT, MRI. We had to go in and remove that nail. It was like probably about this long. It was very thin too. It was like a nail from one of those nail guns.
mhm.
It was just one of those crazy moments while you're fixing things in your garage.
Oh my
And
goodness.
foreign bodies, nail guns, notorious. I'm glad you mentioned that, Andre. They look almost fun to use, but the number of nail gun injuries, both vessel injuries, nerve injuries, you mentioned, one of the ones that I see probably even more frequently than that is nails through a joint. Somebody
Hmm.
trying to nail down a piece of drywall, for example, driving a nail right through their patella and into the joint, for example. I mean, it's just going to be catastrophic injuries.
Yeah. Yeah, it's definitely always interesting to hear the story. Especially during Christmas time, you have a lot of people falling off ladders. They're hanging out their Christmas tree lights, and like, oh, slipped. Um, so, all right, this is another. I'm glad you mentioned painful hardware. um, this was a surgery that someone else did, and I think we can see where the nail or the screw is actually backing out. One of the key things that you can see is the lucency lines. And that just means that there's movement within the bone. And we can see where it was originally, and now it's like basically almost poking through the skin. Um, so if you guys hopefully remember the anatomy, you can tell me later which part of the body this is. Do we have like any suggestions in the chat?
People are saying elbow.
Elbow.
Okay, awesome.
Openon.
Good,
Someone said
good, good. We got
openon.
some smart people here. That's awesome.
I love it.
Good. So another thing too, like I mentioned earlier, we had a patient that had avascular necrosis, and this is what it looks like. The whole, you know, uh, round humeral head was gone, and this is painful. I mean, if you can imagine trying to lift your arm where this is rubbing against each other, it's impossible. I mean, I've seen, people cry just by lifting their arm to show us how active they are. And, avascular necrosis, this is definitely something that has to be managed on a multidisciplinary, aspect with the primary care, um, with just like, a lot of different specialties involved to help this patient. So quickly, just some signs, some causes of AVN of the shoulder. Alcohol. AIDS, sickle cell disease is a big thing that we see a lot of times. Majority of our patient that comes in with AVN has sickle cell. We see it in SLE. It's idiopathic, meaning that they don't know exactly what's causing it. Infection as well, trauma, different diseases, and steroid use is another big aspect as well. Patients, take steroids for multiple different reasons, not just for bodybuilding or just because they want to look like Arnold Schwarzenegger or something. They use steroids to help with other disease processes, and in the process, unfortunately, they get AVN.
And this is one of the reasons, Andre, a lot of folks kind of get surprised when their post-operative course is so long. Is just sometimes, or a lot of the time, you're not dealing with 100% healthy folks, and each and
Yeah.
every one of these conditions keep the patient from healing adequately post-surgery. And so sometimes people wonder, why am I not getting better? Well, there's many reasons, including pre-existing diseases such as this list.
Yeah. And definitely just want to share a quick point in my experience that happened to me recently. And this is one of the things where it's always good to follow your gut as a provider. Do what's best for the patient. I had a patient came in, we did shoulder reduction on the anesthesia. She had a dislocation. It was really hard to reduce. We brought her to the OR on the anesthesia, got the reduction down, and sent her home. Saw her about 3 weeks post op. Um, and I noticed swelling in her legs. She was not very, mobile. She says she sits around a lot, didn't really do a lot of walking. And, I asked her about her history. She's like, I had a clot or a DVT many, many years ago. And she said her primary care took her off her medicine. And something in my gut is like, you know what? Something doesn't look right. The swelling that just came up in the last couple of days, let's get an ultrasound again. So I got a stat ultrasound, and luckily we have that in our facility. Came up as DVT as we expected. Sent her to the hospital, and she got a CT scan, and she had a clot in her lung that was developing. And again, this is not related to orthopedic surgery. So you have to be an advocate for your patients. You have to work as a team. The ultrasound was able to help get everything in order, send the patient to the hospital. Obviously, pulmonology got involved. And again, I mean, you never know what you might do to save someone's life.
And Andre, in lesson number 2 for the day, this is a perfect example of just because you're focused on a specific specialty, that does not take away from the fact that you're a clinician and you have the training to make a medical diagnosis. And saying the words, that's not my patient, that's not my wheelhouse, somebody else can deal with that. That is one of the cardinal mistakes of medicine. So kudos to you for staying active and being a good advocate for that patient. Good job, man.
Thank you. Thank you. All right. So this is another, one of the post-ops complications. This is called like metallosis. Is basically where like the metal starts wearing away in the tissue. It can, on it looks pretty bad when you look at it, in the OR. And it's just like there's different complications of these implants, and this is something too. Obviously, making decision of which implant to use, making sure you use proper research. We tend to go with implants that we've been using for many years. My attendant used implants that he used in his fellowships many, many years ago. Having a recall on an implant, that's horrible. And so knowing your implant and your tools in your tool belt is like a very important thing that you have to bring to these patients, because complications are real and it can be life threatening. um, this is another thing you can see too, periprosthetic fractures. Even after you fix the shoulder perfectly, the patient might have an accident, and no, you have to go back in and basically do a revision and do everything all over. And what we did was we created like a longer stem. So instead of the stem stopping here where the fracture is, we went all the way over here with a longer stem and then do what's called a cerclage to go around the bone to kind of keep that together. This is another example. Let's see if you can let us know if this one is an anatomic or a reverse. We had the arthritis here. We made the cut. Now we can see where we're putting the implant in. And then this is like that final outcome where the ball is on this side of the body and then the poly is going towards the shoulder. So let's see if everyone remember if it's an atomic or a reverse.
Lots of the students are saying reverse.
Woo! Good
Yay!
job.
Good job, you guys.
Good job. Good job. That's awesome. You guys are paying attention. That's great. So see, this is again, what have helped with the tendon is retraction. They say one if you're able to use your two hands to do the function of four, they will love you. You use your elbow to grab one thing, you use your hand to grab something else, and you're grabbing something else in this position. And holding things for a long period of time, it does get stressing on the body, but you have to again learn how to maneuver, adapt, and be the best help you can.
Gotcha.
So just a quick jokes here. Doc, I heard a pop in my knee. It's not good. And one of the things that we tell patients all the time, have you tried icing it?
These are amazing dad jokes.
I love it. I love it.
All right, so that's it for me, guys. I really hope that you guys were able to learn a lot today, and definitely appreciate you guys having me on board.
Well, let's do a little bit of Q&A. Andre, thank you so very much for your time. We appreciate it. Let's do a little Q&A and we'll see what kind of fun we can have.
Awesome.
Yeah, we have lots of questions. And if you look at the chat right now, the students are just saying thank you so much. They loved your talk, and I love
Thank
the
you.
dad jokes at the end. A plus.
Thank you.
So a couple of our students want to know, was orthopedic surgery your first choice out of PA school? Yeah.
It was not. I definitely wanted something in the surgery field, and because like I said, I love getting my hands dirty. I love cardiology. That was kind of like my passion in school. I thought I was gonna do like either uh cardiothoracic surgery or something of that sorts. So when I got into orthopedics, again, my mind was all old people, and it's not,
Mhm.
as you can tell. It's just such a different variety of things. You're always learning something new. So I've actually grown to love it. And it's definitely one thing where you have to learn how to adapt. You have to learn on the spot where, okay, this is not working. How do we fix it? What do we do next? And I love that. I love that it's always challenging me, especially in the OR. You're like, okay, we're running against time. What can we do to fix this problem? The
So
screws is missing. The driver for this is not here. What else can we use?
gotcha. So the challenge and like the, thinking on your feet was really what drew you to orthopedic surgery?
Yeah.
Gotcha. Did PA school help you in any way to like point you to that field?
I would say slightly. I was able to do rotation in orthopedic surgery. I actually did my rotation at NYU for joint disease, but even though it was like the number one, orthopedic institute in New York, I honestly didn't get a lot of experience as a student.
Hmm.
I pushed myself, but it was a teaching hospital, and I think if you're catering to a higher class of people, they don't want the students to do anything.
Yes.
So to be honest, my experience was not that great, but I still gave it a chance, and I'm absolutely happy that I chose this field.
Gotcha. I'm glad you're enjoying it. It definitely seems like you are very happy and thriving in this
Yeah.
field. So we've heard it from a couple of our PAs in the past that, PA school is mainly primary care. Did you have to go any additional training for orthopedic surgery?
Yeah, you're right. The PA field is definitely primary care driven. Fortunately for me, my school had the option of three electives, and I was able to choose interventional radiology, orthopedic surgery, and I did another surgical elective because I knew I wanted to be in surgery. So I was definitely fortunate enough to do my rotations in a surgical field. And I
Yeah.
kind of like strengthened my idea of like, you know what, I really like this. I don't like this. I really like this. I don't like that.
So
So I
your
think, if
additional
my takeaway advice would be, shadow, learn as much as you can and see what's for you.
Gotcha. Love that, love shadowing. That's why we want to create this program, virtual shadowing, so everyone can
Mhm.
see the different fields and whatnot. Some of our students want to know how much, like, um, a, how much control do you have during the surgery as a PA? Like, what exactly is your role? We hear that you're a first assist, but like, what does that exactly entail?
And that's a very good question. I think it all depends on the attendant that you're working with. You have to essentially know your place. That's the number one thing. I think it's important. Not and I said not to get complacent, not to say, hey, this is what I will do. Because my attendant, he has 10 years of experience. He has over 10 years of experience. I have 2 years. That is not comparable. But there's times where he gets stumped on things, and I say, hey, can we try this?
Mhm.
What if we do it this way? And it's all about the choices of words because everyone's listening to you. Everyone's hearing, oh, the PA suggested that it worked, you know, versus, oh, the PA is telling the surgeon what to do. Those are two different dialogues. So if you're able to like communicate with your attendant and say, hey, can we do this versus, oh, that's not working, you should do this. I think it's all about how you come across. People will respect you for being respected by others. I'm the first one to get to the hospital, so they see me as the face of what we're gonna do for the day. I have the nurses that comes up to me, the anesthesiologist. I have the reps, and they're all like, "Okay, what's the plan?" And I do a timeout when I get there in the morning. I'm like, "Hey, this is a 74-year-old female. This is what we're gonna do. We need these implants. We need X-rays. We need 2 units on hold." And you're basically telling everyone what we're gonna do in that case. And I think over time, people respect you for that. And obviously you have mutual respect too, where you do ask for things, but I think it's how you ask for it where it's going to create that perfect dynamics.
Andre, and on the flip side of that, your attending has been working clinically for over 10 years. You have been working for a shorter amount of time, but the opposite is true. I work with PAs who have been in practice in emergency medicine longer than I have, and the amount of learning that goes back and forth is absolutely immense if you just keep your eyes and ears open, and really show mutual respect. So eventually you're going to get to a place where you might go work for an attending who is 10 years your junior, and you
That's
will
true.
have a lot to
That's
teach
true.
them. So always,
That's true.
guys, you're invaluable parts of the team.
Yeah.
You are absolutely inspiring so many of our students tonight, and I think some of them are just wanting to join you in this field. Some of our students want to know: were you able to just immediately start on surgery once you joined your attending, or did you have to have like additional training? Did you have some sort of like length in between from PA school to surgery?
So I did not, and I think it has to do, you have to be hungry, and this is what I try to emphasize to everyone: is like if you show hunger, you show determination, you will learn. The medicine is it's such a change in feel. Like if you can be a sponge and just absorb everything that's being taught to you, you're gonna do great. It's overwhelming. It's very hard for someone to, get into surgery when they first get out of school. But I walked in with confidence. When I give my lectures, I say, be a duck in the water. And they're like, why would you say that? You look at a duck on top of the surface, they're chill, they're collected, they're calm. Below, they're pedaling like crazy to get across. And that's what you have to do. You fake it till you make it. You go in with confidence. And you know what? I'm going to learn. I'm going to do my best. I'm going to make sure that you are very happy with the decision to take me on as a new grad. And it's possible. You'll find that person who's willing to train, who, appreciates your eagerness to learn, and that would basically avoid an extra year or so of a fellowship program or some kind of training program that they have for PAs.
Gotcha. I love that analogy that you're a duck in the water. That's so great. Um, what like a couple of our students, like I said, are absolutely inspired by you, but are still, deciding between MD and PA. Can you touch on some like pros and cons, and like why did you choose to be a PA?
Yeah, I definitely think, it comes down to your lifestyle. I run into issues where someone say, "Hey, you're so good. Why don't you become a doctor?" Um, you're just like, "Why don't you go to med school?" And, for me, I like the diversity. I like the idea that as a PA, I can be in orthopedics. I can also work as emergency medicine. I can work in cardiology. I can work in dermatology. I like the flexibility. Um, and, the downside to the PA field, obviously, is not having that knowledge base or that credential to say you make that final decision. And I think it comes down to your personality with like if you're okay with saying, you know what, I'm not the boss, he is, he's gonna give the final answer, and you're not gonna get offended by that, then it's okay. You also have to realize that even my boss has a boss, and his boss has a boss. So there's always going to be someone on that ladder that goes up, and it comes down to the time. If you want to, invest the time to go to school for this many years or less, it's really a hard decision. But I encourage people. I was like, listen, shadow doctors, shadows NP, shadow dentists, shadow PAs, shadow everyone, and see what works best for you, what lifestyle you want to live, um, what you want to do as a person, because at the end of the day, you have to be happy.
Mhm.
These hours are long. I work average of maybe 60 to 70 hours a week, but I love what I do. If you're doing it for the money, it's not going to work out. I mean, there's doctors that don't like their jobs, as there are PAs that don't like their job.
Mhm.
It's all about what you're passionate in.
Gotcha. Just, find what's the right fit for you. Can you actually touch on like what your life is like, a week in your life? Are you doing surgeries every day? How often are you on call? Because you mentioned that you're going to be on call this
Yeah,
weekend.
so that's a good question. We're on call like maybe 3 days out of the month, which isn't too bad. It falls on the weekend. Sometimes it falls during the week. Mondays are my clinic days. Tuesday surgery day. Wednesday it can be a combo. Thursday clinic. Friday could be a combo as well. So the reason I chose this job also, as a new grad, you want to get your hands dirty. And if you can get as much experience while you can before the kids, before the major responsibilities, I think you're basically setting yourself up to be successful.
Hmm.
So if I go to emergency department right now, I have suturing experience. I have, casting experience. I have splinting. All these things I have from being on call for seeing different things. I can go into cardiology and say, okay, well, half my patients are, hypertensive, diabetics that I have to review their records. Having these knowledge, it kind of helps you to branch out into different fields. And I
Hmm.
think it's important to be hungry when you first get out and just learn as much as you can.
Gotcha. Um, so a couple of our students really want to know, how much charting do you do?
Oh, a lot. I hate it. I absolutely hate it. My attendant has a scribe, and I get jealous every single day.
You can't get a scribe?
No, it's not in the budget for my facility.
Oh.
I know. I do all the work myself.
Hopefully you can get a scribe in the future, but would you say like it takes up a huge chunk of your day?
Yeah, definitely a lot. Because you're dealing with different things. You're dealing with, I do my notes, I do my own orders for physical therapy, medication, and then you're also dealing with stuff from the hospital. Paid nurses are calling, hey, this person is getting discharged. Can you put the orders in? You're planning for surgery for next week. You're having like the MAs asking, hey, is this the surgery you're doing? Is this the equipment you need? So multitasking in surgery is absolutely key.
Gotcha.
Having the ability to just, compartmentalize things. And you also have to realize that you're human. You're going to have stress off your personal life, and you have to balance that.
Yeah. So you mentioned that you worked with like lots of different healthcare professionals. A student asked, what extent of communication do you have with like physical therapists for your patients during post-operative management? Do you get to follow up on your patients? Like, how involved are you?
Yeah, I definitely love PT. PT physical therapy is like our go-to. It's our love. We definitely stay in contact with our physical therapist. We get reports faxed to us on the patient's progress. We send updated orders every couple weeks to the therapist to, hey, let's move on to phase 2 or phase 3. Let's get this much motion out of the shoulder. So we stay in very close communication.
Gotcha. Another interesting question is, do you ever run into a situation where you disagree with your attending's decision on what to do? And then how do you navigate that?
And that's a very, very good question. We've fortunately only have like maybe one or two instances where, I would disagree just because in my mind, I can see where this is not going to work.
Hmm.
And, my attendant, he's very particular with things. So if his mind is set, like, this is what I'm going to do, he's going to try it over and over and over and over and over. until it's like, okay, it's not gonna work, and then he tries something else. And I think that's kind of like the only, situation where he has something, and I'm like, I don't think that's gonna work. But again, I'm not the surgeon. You have to know your place. And then after he tries it, doesn't work, then what if we do it this way?
Mm-hmm.
And you kind of break the ice, because again, you want to be protective of the patient, in the sense that making the attendant mad and upset and irritated is not beneficial for the patient.
Mm-mm.
So
Yeah.
you have to, break the ice and say, hey, what if we do it this way? And he's like, okay, sure. Versus, like I said, man, that's not working. This sucks. Like you're bad.
Yeah. That
There's a
wouldn't go well.
I
there's a
would lose my
concept
job.
in medicine. It's called heuristics, heuristics, in which you use past experiences. Perhaps you've had a positive or negative experience, and you essentially kind of make associations between X and Y, and maybe some shortcuts. And sometimes these heuristics, these little shortcuts, they're not very popular with others, but those are things that have worked for you many, many times. And sometimes that's one of the hardest things in medicine, is having a discussion about another person's heuristics, and you may totally
Yeah.
disagree with it. So definitely, I'm glad that professionalism is always gonna kind of a top, because a lot of people get in trouble when it comes to that relationship. So I think it's amazing that you have such a wonderful relationship with your attending, and you respect the attending's heuristics, as I'm sure he respects yours.
Yeah, and like you said, I think it's definitely respecting each other. I see, other PAs that, obviously might struggle with certain things, and it boils down to their attitude. It boils down to, oh, I'm not gonna do this. Like that's not my job. And yeah, I get it. You have to set boundaries, because you don't want to be seen as, okay, you're no better than this person, or you're no better than that person. But at the end of the day, I don't look at life that way. I look at life as, what can I do to help, and what can I do to get the process done most effectively, and in a time efficient way.
That's amazing.
If No, sorry, go ahead.
No, I was gonna say that's pretty amazing.
Right.
Yes.
I
Rachel,
have,
let's take one or two more
yeah.
questions, and we'll go from there.
Dr. Salazar, you read my mind. We have two more fun questions. The first question is, have you ever had a patient case that you helped with really stick with you in your career?
Yeah, definitely. One that really stood out was that DVT issue that I told you about, and the other one, was a patient that she actually had a tumor on her um, femur, and there was a fracture. No, we did the surgery, um, and it was like one of those decisions where, you know, do you fix the fracture so you can give her more time to, be mobile and have a better life? Or do you let it be, and that increases her risk for more complications? Knowing that this is someone who is not going to live to see a long time. So that was definitely, meeting that patient. And unfortunately, after surgery, she had, like, infection, and then eventually, she got better. Then she got back to the hospital, and the cancer kind of took over. But it really stood out to me, because knowing what to do in that situation is really hard. Sometimes you have to make a tough decision. you know did we take more time away from her family by doing the surgery? She's in the hospital more, increased risk of infection. Or could have been a situation where we let not do the surgery, and things got worse. And it's you never know what the right answer is. I think it's one of those things that, where you're not sure what to do. that really stands out to you?
Gotcha. And then our last question is, how does being in orthopedics affect your day-to-day basis? Like you mentioned, no feet on the passenger side, being up. So how else does it affect your day-to-day?
So I'm a speed junkie. I love, you know, I used to race cars in undergrad. I had a
Oh.
hooked up car, big muffler, big turbo, big sound system. I was like living on the edge in undergrad, you know, going into, medicine and seeing everything on a daily basis. I probably drive slower than your grandma. I love motorcycles, but I refuse to get one for myself because really bad fractures that we fix, 90% of the time is from a motorcycle accident. So I think that has kind of like changed my perspective in just being, safer when it comes to driving, leaving early, not being in a rush, not being distracted while you're driving with being on Facebook or Instagram, making
Mhm.
videos, because it's a split second. All it takes is a split second.
All right. Thank
Thank
you
you,
so much.
Andre. Last
Uh,
question for me, Andre. Someone asked earlier, any thoughts on the change of name from physician assistant to physician associate? Any strong feelings? If you heard about that, great. If not, it's no biggie. Wanted to see
Yeah,
what you thought about it.
I mean, I think, I definitely support it. I think it can be, I see both sides. I see the people who are against it, says, okay, it might give patient a wrong understanding of your role, where they might think you're a physician and you're just a friend of the physician. And I also hear the points of, you know, PAs are saying the assistant kind of has a negative connotation to it. And for some patients, they don't realize how much work you do as a PA, because as a PA, like, you're making decisions that will affect patients' lives, medication, um, just like the treatment versus the all these things that you do. If you're wrong, things can go really bad. So I think having that name and then realizing your role, that hey, you're still not the physician, you're working with the physician to do the best you can for this patient. But at least this name will maybe give you uh, a different recognition in society. I'm okay with it. I'm for it.
Very cool. Well,
fabulous.
Andre, thank you so very much. We really appreciate you being here. And on behalf of the entire virtual shadowing team, we just wanted to thank you for spending the time with us and share your story. You're truly an inspiration. One of the things that you and I discussed before this session was diversity in the workplace, and we're just so excited to see that underrepresented minorities in our country, women, are going into the workforce and representing us well. So for that, we're
Awesome.
eternally grateful. So Rachel, take it
Awesome.
away.
Uh, yeah, so this is the assessment information. Sorry, it's not due 9/1. It's supposed to be 7/1. Sorry about that. So it's due next week, next Thursday at 6:59 p.m. Central Standard Time. Thank you to the person who pointed that out. You have, a couple attempts, but please be sure to download the certificate afterwards. And on our side, your shadowing is not recorded unless you download the certificate. So take your time, do the quiz. It's not super hard, just making sure that you're actively listening. And yeah, I hope you guys had fun. I sure did have fun. Andre, I hope you had fun as
Yes,
well.
it was amazing. Thank you.
Uh, Andre, if they wanted to hear more from you, do you have any social media that you want to plug?
Yeah, you can definitely follow me at the PA Life Coach on Instagram. And if you have questions, advice, I'm gonna keep it 100%. So you'll definitely get some great advice from me.
All right. Thank you so much. The students and I love the session. As Dr. Fowler would say if he was here, our YouTube recordings get 5,000 views, and every student, every healthcare provider, sees about 100,000 students. So you touched like 500 million lives tonight. So thank you
Wow,
so
that's
much for
amazing.
donating your time. And on behalf of the team, I wish you and everyone a great night.
All
Thank
right,
you.
good night, guys.
Thanks,
Bye.
everybody.